But again, my name is Claire Anderson Sante, and I'm the program director with Gilda's Club Kansas City. And we offer this class today in partnership with Turning Point. And I have started the recording, and I'm going to turn it directly over to Jamie Myers. Thank you so much for being here.
My pleasure, Claire. Thank you so much for that nice introduction, and welcome everybody, and happy Friday. It's always good to see that day of the week come by. So as Claire mentioned, our topic today is cancer and cancer treatment related cognitive changes. You might have heard it also referred to as Chemobrain. And as she mentioned, I'm from the University of Kansas Medical Center. And today what we'll be spending time on is what is this phenomenon and why do we think it happens? We'll spend a good deal of our time today, though, talking about what you can do about it. I will give you both some common strategies that I'm aware of because of the people that I interact with who have experienced quote unquote Chemobrain, but I'm also going to spend some time showing you what's evidence-based, what the research shows. And then we'll finish up before we open it up to questions is I will give you an overview of what some of the current research is that we're conducting right now, and then what some of our future plans are so that you'll know kind of what's coming down the pike. So to start with, what is cancer and cancer treatment related cognitive changes and why do we think it happens? On the left-hand side of this slide, you can see all of the different names for this phenomenon. I've highlighted Chemobrain in red because it seems to be the one that's kind of gotten the most traction as far as, being in the public eye. But in truth, Chemobrain is really a little bit of a misnomer, because we know that it's not just chemotherapy that can cause the issues that people describe. The cancer itself, we know, can cause cognitive changes, as can a number of other types of therapy that people would have after they've been diagnosed with cancer. And some examples of that are here. Obviously, chemotherapy is one, kind of where things began to hit the radar screen. But endocrine therapy also has been related with cognitive changes. And by endocrine therapy, I mean the medication that someone with breast cancer may take to suppress estrogen in the body, because we know breast cancer is sensitive to estrogen. And by the same token, for men with prostate cancer, we do treatment called androgen deprivation therapy, which suppresses testosterone in the body, which we know prostate cancer is sensitive to. Suppressing both those hormones has an impact on memory and concentration. Radiation therapy is also listed on this slide, and not just radiation of the head and neck, where you might expect there to be cognitive changes because the brain would be in the treatment field, but even radiation therapy of other parts of the body can cause some reactions similar to what chemotherapy causes and be associated with cognitive changes. And then the last thing I've listed here for you is immunotherapy. There are many new types of immunotherapy on the horizon now, one called CAR-T, which is probably the most well-known type of immunotherapy right now, is known to cause some issues with cognitive function. What remains to be seen are whether some of the other types of immunotherapy too would have cognitive changes, like treatment with checkpoint inhibitors. And we'll talk about that just a little bit at the end. So what kind of cognitive issues are we talking about? Well, just a broad general definition would be very mild forms of cognitive impairment that are attributed to cancers that start outside of the central nervous system. So we're kind of differentiating between individuals who have a primary brain tumor or central nervous system tumor with people that have solid tumors or more liquid tumors that start outside of the central nervous system. What people describe is becoming more forgetful, being absent-minded, having trouble with focus or concentration. Probably the most common description is people that are having issues finding the right word. That's probably the most common thing that people report. People also report having trouble with misplacing things, issues with multitasking, when maybe that was an area where they really excelled before their cancer diagnosis. And then for a smaller percentage of people, issues with driving and directions and getting to places that might be very familiar to them. As far as the types of cognitive domains that are affected, you can see them listed for you here on this slide: memory, psychomotor and processing speed, and something called executive function, which is kind of a fancy name for being aware of and being able to execute all of the steps that would need to be done to accomplish a complex task. Those things are probably the most common cognitive domains where people will experience changes. People ask, well, when would this happen? What's the time frame? And like many things that go along with these types of cognitive changes, the answer is it's very variable. For some people, they'll notice changes at diagnosis or very quickly after starting therapy. But for others, it may not be until after they've finished all of their primary treatment for cancer and their life patterns begin to get back to more what was normal for them pre-diagnosis, that they realize something's different here. Something is different with how my brain is functioning. Likewise, the level of severity is very variable. There's a percentage of people at the left-hand side of the curve that may have very little issues with cognitive trouble. People on the far other side of the curve have great difficulty. The bulk of the population would be somewhere in the middle, where the level of severity is more moderate. And then, same song, second verse, the time for recovery is also variable. I will say that the bulk of people, the majority, within 1 to 2 years after getting done with all of their treatments, will be very, very close to being back to what they considered their baseline. But there is a smaller percentage of people who have more long-lasting issues. And if we could figure out why a smaller percentage of people have more long-lasting issues, it would be extremely helpful in knowing how to prevent this from happening at all and how to treat it when it happens. So the consequences, as many of you may personally be aware, can be quite significant as far as the impact on one's quality of life, whether that be at work or at home or socially. And you can see here that actually this is quite a prevalent thing for people. The estimates range anywhere from 75 to 95% in the literature, a little bit higher, say 83% for people that have been diagnosed with breast cancer. Anywhere from 30 to 75% of people, depending on the type of cancer, may report cognitive issues before any kind of treatment is started. And as I mentioned, there's a subset of people that might have more long-lasting issues. And it's a very complicated area to study because there are any number of factors that can contribute to this and also to confound the picture. One of the biggest challenges that we have is the tools that we have available to us to measure it. Now, you might say, well, the gold standard is going to be neuropsychological testing, which maybe is the gold standard for other types of cognitive changes. But the biggest issue here is that the level of severity that people experience, they may be able to really compensate for on a neuropsychologic test and score well within normal limits, yet they themselves know something is very, very different from what they were like cognitively before cancer and cancer treatment. So there's a little bit of a disconnect between people's personal experience and how well they perform on a standard neuropsychological test. Plus, those types of tests can be very time consuming and may or may not be available to everyone, depending on where you live and what access you have to various types of assessment. And here's the laundry list of other things that can muddy the picture. We know as we age, our memory and concentration age too. And as we age, we're less mentally sharp. I already mentioned some of the issues that can go along with hormonal changes as far as estrogen and testosterone. Everyone starts out at a different baseline, and that can affect ultimately how much issue someone would have over the course of cancer and cancer therapy. There is some evidence to indicate that there may be a genetic component here, and that maybe it's the genetic predisposition that may answer the question as to why a percentage of people have more trouble than others. Maybe they're just more predisposed to having cognitive effects after cancer and cancer therapy. But then look at all of the other things that can play a role. Over and above the changes that we know can happen because of the cancer and the cancer therapy, there are things that accompany cancer that can make things worse. The fatigue, the overwhelming fatigue that can go along with cancer therapy, dropping of hemoglobin levels or anemia that go along with cancer and cancer therapy. Depression and anxiety can also muddy the picture. We know when we're depressed or anxious, it's not our best time cognitively, so that can further complicate the changes that people are already experiencing. The type of chemotherapy can play a role, how long it's been since someone's finished treatment, and we'll talk a little bit today about the fact that what we eat might also be involved. So here's a picture that shows you some of the possible mechanisms behind why this happens. There is something in the body called the blood-brain barrier, which protects our brain from toxins. And as it turns out, some degree of chemotherapy can cross that blood-brain barrier, maybe more so than what we first thought. We mentioned hormones and genetic susceptibility already, but when the body is exposed to cancer or cancer therapy, it mounts what's considered to be an immune response. It sees something as foreign, something as toxic, and it tries to fight it or combat it. And to do so, it produces some things in the body called cytokines. And cytokines we know in the bloodstream, or as they cross the blood-brain barrier, can affect people's memory and concentration. And then the last thing on this slide mentions DNA. And actually, there's a school of thought that says that being diagnosed with cancer and getting treated for cancer might actually accelerate the aging process in the brain. So these are all of the reasons which go behind what people are experiencing. But what really put this on people's radar screen, if you will, is when research indicated that there actually were changes structurally and functionally in the brain as a result of cancer and cancer therapy. And once the healthcare field recognized that on a scan, you could see changes in gray matter and changes in connectivity on a CAT scan or on a functional MRI or magnetic resonance imaging scan, the healthcare world really kind of finally started to sit up and take notice that, hey, this is something we really should pay attention to. It's not just, a one-off. And here is a slide that if you've ever heard a talk on Chemobrain before, I know you've seen this slide, so apologies for those of you for whom this is a repeat. But what this slide shows you are the MRI scans from female twin sisters. And one of the female twins has been through breast cancer and breast cancer therapy, and the other has not. And both of them had an MRI scan. And as you progress from left to right across the scan, they are in the MRI machine and they're performing a cognitive task that gets more and more difficult over time. On the woman on the top, on letter A, you can see has a lot more of her brain lighting up as she's doing the cognitive task than her sister, who's on the bottom, who's B. What this indicates to us, both of these women performed just fine on that cognitive task. But the woman who'd been through cancer and cancer therapy, the woman on the top, is working a lot harder to get that task done. And this was it was a seminal research publication that really helped the healthcare field know that this was a true phenomenon. Okay, enough of the science, right? So probably what you're all really here for is, what can we do about this? What can we do to make this better? And so I told you I'll talk with you about many common strategies that people use, but I'll also talk with you about what the research shows. So here are a number of strategies that people describe using to help combat Chemobrain or cancer and cancer treatment-related cognitive changes. Number one is to try to rule out or treat the things that can further complicate it, like fatigue, distress, which includes anxiety and depression, and insomnia. Another word for insomnia would be sleep disturbance. Not everybody thinks of themselves as having insomnia, but I would be willing to bet that many of the people on the line today who have been through cancer and cancer therapy might describe not sleeping well. So there are strategies to help minimize fatigue, minimize distress, and help people sleep better, that's a good place to start. So we'll talk a little bit about sleep hygiene, and then we'll kind of continue on down this list with other strategies that people have used. Sleep hygiene is actually something that there are people who specialize in, people who are certified in cognitive behavioral training for insomnia, are masters at helping people use strategies that will help them sleep better. And just a few of these, of course, we could spend all day on this, right? But just a few of these, for those of you who want to get a little exposure to it, are not to have alcohol, caffeine, or nicotine at bedtime or close to bedtime, because nicotine, obviously, and caffeine would be too stimulating. And alcohol might actually help you fall asleep, but it will not help you stay asleep. It will cause very interrupted sleep. Keeping the room very dark and very cool is a good strategy. Going to bed at the same time and getting up at the same time consistently throughout the week, weekend, weekday, helps train your body to associate being in bed with sleep. And minimizing the amount of arousal and light in the room, including electronic devices. It's strongly recommended that you not, have your screen, your blue screen, right with you in bed for two reasons. One, the light is stimulating, and two, you may be looking at material that also would cause arousal. So those are just some of the strategies. Exercise. The more active you can be during the day, the more fatigue is minimized, which is a good thing, but also it helps you sleep better. But the recommendation for exercise would not be to do it right at bedtime, because it would be too arousing. So that's probably enough on that for today, or we'll overgo our time. But I will point out that there are specialists that deal with behavioral training that can help people break out of a pattern, a negative sleep pattern, and help them sleep better. I also mentioned that we talk a little bit about nutrition. And we all know that the American diet is not ideal, right? We have a high intake of processed foods and fast foods, and our diets are very high in added sugar and trans fats. And all of those things would be considered inflammatory, like those cytokines that I mentioned when your body mounts the immune response. The goal, as the research is beginning to point to, is to have a diet that is anti-inflammatory. And for this, you would want one that is high in omega-3 fatty acids. And some of the foods that would be good would be fish, like you see listed here, non-hydrogenated oils, avocados, wonderful, and leaning more towards whole grains and vegetables rather than fried foods and sugar and processed foods. So a nice picture of a healthy diet would be on this slide. The Mediterranean diet is perfect. It's on the left-hand side, but the plate on the right is also great. You'll see about a fourth of the plate is meat or protein, and the rest of the plate is vegetables and lentils. So this is kind of what we're striving for as we're learning more about nutrition. In addition to those strategies, though, another thing that can be helpful is a mindfulness approach. And this would be being very aware of your own body and your own mind and your own situation, but also being accepting of some of the differences that you're now coping with, and accepting a little bit of imperfection. Like, don't be so hard, on yourself. If maybe multitasking is not going to be something you excel at after you've been through this cancer experience, but focusing your energies on the things that are priority and doing one thing at a time instead of trying to do 5 things at a time might be a good strategy to reduce frustration and help you be more successful with the things that are really important for you to remember. Something else that can be helpful is social support. Friends and family are always asking, what can we do to help you? We want to do something. We want to do something positive. If there are things that are extremely important for you to remember, ask for some help. Make sure I get to this appointment. I don't want to forget this. Call me 20 minutes before I'm supposed to leave the house so that I know that I'm going to get there on time. And then there's a number of technological things we can use now to help us remember what we want to, techno support, if you will. For the people who are having issues with driving, the GPS can be a best friend. The last thing I'll mention on this slide is some humor. It's always a effective, positive coping strategy if you can find the humor in the situation, which might be easier said than done, given some of the frustrations that can go along with these changes that people are experiencing. The jury is a little bit still out on whether things like crossword puzzles or Sudoku would be magic in any way, shape, or form to help stimulate the brain. But what the research would indicate probably is the most important thing here to challenge your brain is to learn something new, something novel to you, something that's a little bit out of your zone. For example, trying to learn a new musical instrument, would be one example of something that might be outside a person's paradigm. But organizational strategies can be very, very helpful as well. Some way, shape, or form of writing down what it is you want to remember and having a system that works for you as a reminder. People find that very helpful. So those are kind of all of the things that people would share that they have found helpful. So now what we're going to shift gears to a little bit now is I'm going to start to tell you what some of the evidence is showing might be the most beneficial so far. And this slide talks about 3 different things. One is exercise, one is mindfulness, and one is cognitive rehabilitation. And we'll talk about all 3 of these a little bit. Exercise really is where I put a lot of my emphasis, because we know that exercise, the evidence is very, very strong, that exercise reduces fatigue, even though that seems completely backwards, that when you are just exhausted from your cancer and your cancer therapy, the last thing you may want to do is go out and walk. But in truth, the evidence is extremely strong that if you can get some level of regular activity into your daily pattern or your weekly pattern, the level of fatigue will go down. The National Comprehensive Cancer Network, or the NCCN, actually has published guidelines about exercise for people who have been through cancer or who are experiencing cancer. The recommendation is to try to get to a point where over the course of a week, in some way, shape, or form, you're getting in about 150 minutes of moderate exercise. That can just be walking. It doesn't have to be anything, insanely intense. Or 75 minutes of more vigorous activity. The evidence shows this will reduce fatigue. It will improve sleep. It can reduce risk of recurrence, which is very exciting. But for the purposes of today's talk, also may improve memory and concentration, because you're increasing blood flow to the brain, and you are going to decrease those products of inflammation, those cytokines that I told you about. So exercise would be something that would be very beneficial on a number of different platforms. The second thing mentioned here is mindfulness, which I mentioned earlier. Mindfulness or meditation, which would be another type of word for it, actually decreases the body's stress response physiologically, also decreases those products of inflammation that I mentioned to you. And very interestingly, there are forms of mindfulness-based exercise, which might be the best of both worlds, because you're combining both exercise and mindfulness. Lastly, you'll see something called cognitive rehabilitation training, which is an umbrella term, but it includes what's called psychoeducation, which would be learning about the what's and the whys of why this happens, and given a toolbox of strategies that you can try to help make things better, along with different behaviors like exercise and nutrition and improving sleep, and also something called cognitive training, which is where you're actually practicing some exercises that have been shown to help with brain function. So all 3 of these would be something that the research is showing to be promising. So drilling down just a little bit real quickly, we did do some research in this area a few years ago, specifically looking at exercise for women with breast cancer. And we enrolled women all across the United States. We had about 360 women who took part, some of whom were people who were diagnosed with breast cancer and some who were not, which are the HCs or controls. We had all of the women fill out some self-report instruments on their rating of how they felt they were doing cognitively, and as well as what other symptoms they might be experiencing. And we looked at the amount of activity that those women were taking part in. And we also looked at what's called their body mass index, which is based on your height and weight, how much body mass index or per meter squared volume your body takes up. And what we found was pretty interesting. The women who had been through breast cancer and breast cancer therapy reported worse cognitive function than the women who had not been through breast cancer treatment. The women whose body mass indexes or their weight was higher than what would be recommended for their frame reported worse issues with cognitive function. But really interestingly, the women who exercised frequently had better cognitive function, even if their body mass index was higher than what was recommended. So exercise actually mitigated that excess weight on cognitive function. So that was pretty exciting. A little bit later, because we were very interested in mindfulness and mindfulness-based exercise, we did another study where we enrolled women to one of three groups. And these were women who'd been through breast cancer therapy. One group of women once a week for 8 weeks did a type of mindfulness-based exercise called Qigong, which is very similar to Tai Chi, but a lot easier to perform. And you have to be quite as skilled to like yoga or Tai Chi. You might have to have a lot more balance and flexibility. Qigong, really everybody can do Qigong. So one group did this for 8 weeks. One group did something called gentle exercise for 8 weeks, which is the same movements and postures as the Qigong group, but without the mindfulness component. And then the third group took part in a weekly support group that was tailored for the needs of women that had been through breast cancer. And what we found was the women who were in the Qigong group actually over that course of 8 weeks, their self-report improved for both cognitive function and the amount of distress that they were experiencing. Processing speed got better for the women in the gentle exercise group. And interestingly, the support group on a test of verbal fluency got better. But what we took home from this study was that mindfulness-based exercise might be superior to exercise alone for self-report of cognitive function, as well as the amount of distress after being through breast cancer therapy. So cognitive rehabilitation therapy is also something that we have looked at, and we've been very excited to partner with other investigators at Cedars-Sinai in Los Angeles. And this cognitive rehabilitation program that they've been putting on now for several years is called Emerging from the Haze, which I think is a very appropriate title. The first pilot study that we did with them, they delivered this 6-week program, which, as I mentioned, provided participants with a toolbox of strategies to practice and experience to try to see what worked best for them to make cognitive function better. We did this over 6 weeks. They broadcast it to us live over the internet. Actually, pre-COVID, we were doing this over the internet, which was kind of cool, except we were all together in one room in Kansas City. And then we had a group of another people in Topeka. And then there was a group of people in Los Angeles, but we could all see and hear the content and we could have dialogue together. And we enrolled about 61 ladies who'd been through breast cancer therapy treatment to this program. Half of them got the intervention right away, and half of them were on what's called a wait list, which means we collected data from both groups. And then after all the data were collected, the women who'd been in the wait list got to go ahead and come in and have the Emerging from the Haze program. And we had people fill out those self-report instruments about cognitive function. And we also did some blood tests, little finger stick blood spot tests, like when you have your blood sugar tested for diabetes. And we looked at the amount of omega-3 fatty acid index that people had in their blood. And we looked at whether or not that was associated with cognitive function, kind of what we were talking about in that nutrition slide, what I shared with you a few minutes ago. What we found in this pilot was exciting. The women who were in the intervention group that got to do the emerging from the haze up front reported statistically significant improvements in their cognitive function after the program. And we did see an association between the omega-3 fatty acid levels and people's self-report of cognitive function. So where we are now is we are in the process of doing another pilot with them, which I'm going to tell you specifically about here in a couple of minutes. But this program, instead of having people together in the room, which we can't do now because of COVID, the entire program is being delivered over the internet, which means you don't have to drive anywhere. You can be anywhere as long as you have a device where you can get online and experience the program. And we ultimately are going to study a version of this that's been pre-recorded, because it might be difficult to be in the chair at the right place in the right time to experience the program, whereas if it were pre-recorded, someone could watch it at their leisure. And our ultimate goal is to conduct this research through the SWOG Clinical Trials Research Network so that we can have it all across the United States. So going on now along those same lines to talk about future and current research, that same program that I just told you about, Emerging from the Haze, I mentioned we're doing a pilot right now. In the past, we did just women with breast cancer. But this pilot, it doesn't matter what type of cancer the person has had, they just need to have finished their chemotherapy or radiation therapy so that those treatments aren't going on during the program. It's okay to still be getting things to suppress estrogen or testosterone, and there's some other things that it's okay to still be receiving. But we want the people to have finished their chemotherapy and their radiation therapy to be taking part in this program. We have another group starting up next week, which this program today is very timely in case this is something that you're interested in. But it starts up on January the 28th on Thursdays, once a week for 6 weeks, from 11:30 to 2 Central Time. And you would need to have a device where you could watch the program. And we would ask that you would fill out some questionnaires online before the program starts next week, about a week later, and then again 6 weeks later. So when we get to the end of today's program, we'll take questions about this, but I'll also have my phone number and my email in a slide that we can leave up where you can see it, so that if you want to ask me about this, you can, since it's starting up pretty quickly. The other study that we have going on right now is back to women with breast cancer again, but this is an intervention that combines exercise and game-based cognitive training, which is also called speed feedback therapy. And we're actually collaborating with Hiroshima University in Japan, and we have a center in Denver, and we have people involved in Indiana. So it's an international collaboration. But the purpose is to see if this combined exercise and brain training will be effective in improving cognitive function. And for this, we're actually enrolling 120 people, 60 in the US and 60 in Japan. 30 of those are being enrolled through KU, and then 30 will be enrolled in Denver. We are having people complete the self-report questionnaires that I told you about. The exercise intervention involves cycling, portable cycling pedals that women have within their homes that we lend to them for the study. And those cycles are connected by Bluetooth to a tablet. And while the participants are cycling, they're playing the brain games on the tablet. And so there's a connection, a mind-body connection between the speed of the pedaling and the speed at which the brain games are being provided on the tablet. And we're assessing the women at baseline and again at the end of the 4 weeks, and then again at 16 weeks for both self-report of cognitive function, but we're also doing one very brief neurocognitive test along with it. I'm excited to say we completed our enrollment on this in Kansas anyway. We have our 30. The other sites are still finishing up. So we'll be excited to analyze these data, and maybe in a few times when I give this talk, I'll be able to tell you the results. During that study, we're also collecting those little finger prick blood spot tests because we want to see if we can show a difference in those cytokines that I mentioned earlier, but also some products in the blood that are called neurotrophic factors that show brain health. So we're looking at both inflammatory factors and brain health factors to see if we can help explain how the mechanism of the intervention is working to improve cognitive function. We have a study that's been conducted for men with prostate cancer as well. This was a diet and exercise study over the course actually of 12 months, where we collected data from men and gave them individual coaching on their exercise and their nutrition. And we're in the process of analyzing these data now, but we're also now looking at potentially adding to that intervention the cognitive behavioral therapy for sleep disturbance that I mentioned earlier. So the pilot that we have going now for men with prostate cancer is for those who are receiving androgen deprivation therapy, where they're decreasing the testosterone. And these participants, we're demonstrating that we can assess their fitness level electronically, and we're demonstrating we can assess their cognitive function electronically because we're providing each participant, we're loaning them a study iPad. So you don't have to have your own device and you don't have to have internet service at your home because the iPads have data plans. So we're assessing those things. And then each of these men are taking part in a 4-week sleep intervention where we're using the cognitive behavioral therapy to help improve sleep. So to be eligible for this, the man would need to have prostate cancer, be on androgen deprivation therapy, and be experiencing some trouble with sleep. So that's available to people if they're interested as well. We need to enroll 15 men, and we have 3 right now so far. So we've got some room for more folks, and we'll be conducting this through the end of June. I mentioned checkpoint inhibitors a few minutes ago, that it's a type of immunotherapy that might have an impact on cognitive function. So we also have a study going on right now for people that are getting ready to start checkpoint inhibitor therapy as first-line therapy. So they haven't had chemo. This would be the first type of treatment that they receive. And we're going to assess their cognitive function at baseline and then again at 6 months to see if we will find whether this type of therapy has an impact on cognitive function. And the last thing I'll share with you is I mentioned that there's a disconnect between how people report their cognitive function, verbally, versus how well they perform on those tests, those neurocognitive tests, and the fact that they don't match. We feel strongly that those neuropsychologic tests may not be the most accurate way to measure cognitive function. We feel like the best way to measure cognitive function in this setting is to measure cognitive effort. How hard is the person working to get that task done? And as it turns out, as you do a neurocognitive task, and the more cognitive effort you expend, the more your pupils dilate. So that's something that can be measured. And what you see pictured here on this slide is a little camera that's a desktop camera that can measure people's pupils, without touching, while they're doing a cognitive task. And we've done some work in this area for women with breast cancer. We enrolled 23 women with breast cancer and 23 women who had not had cancer. We had them, we took pictures of their pupils while they did cognitive tests, and we also had them fill out self-report instruments of cognitive function. And what we found was the women who'd been through breast cancer reported worse cognitive function than the women who hadn't been through. Both groups performed just fine on that cognitive test. But the women with breast cancer, I apologize for the ringing phone. The women with breast cancer had more pupil dilation. In other words, they were working harder to get the job done. So we are taking this research forward. We have a grant being reviewed now by the National Cancer Institute. And so cross your fingers and light a candle that they will like our proposal and that we'll be able to do another study that's a bit larger. So with that, I will leave my cell phone number and my email number up here on the slide while we open it up for questions so that you can jot this down. If there's something that you're interested in, feel free to reach out to me.